There is one drink that the majority of American men over 60 consume every single day, often multiple times per day, that is quietly and consistently making their prostate symptoms worse. It is not an obscure substance. It is not something you would typically associate with prostate health. It is something that is in virtually every home in America, that is consumed with meals, with medications, in social settings, and as a fundamental part of the daily routine that most men have maintained for decades. And the reason its connection to prostate and bladder symptoms is so rarely discussed is that its effects are gradual, consistent, and easily masked by the general background noise of aging lower urinary tract symptoms, making it virtually impossible to identify through casual observation without deliberately removing it and watching what happens. I am Dr. James Whitaker, board-certified urologist, and the drink I am referring to is alcohol. Specifically, regular alcohol consumption in men over 60, even at levels that are conventionally described as moderate, has multiple direct, mechanistically documented effects on prostate tissue, bladder function, and urinary symptom severity that I am going to explain in clinical detail today. I want to be clear about something before I continue. I am not making a moral argument about alcohol. I am making a physiological argument, grounded in peer-reviewed urology and pharmacology research, about what a specific chemical does to specific tissues in the aging male pelvic region. Men deserve to have this information so they can make genuinely informed decisions. Alcohol affects the prostate and lower urinary tract through 4 separate and distinct mechanisms, each of which independently worsens the symptoms that men with BPH and overactive bladder experience. When these 4 mechanisms operate simultaneously, as they do in any man who drinks regularly, the cumulative effect on urinary function can be substantial. The first mechanism is direct diuresis. Alcohol is an antidiuretic hormone antagonist. ADH, which I described in the video about nighttime urination, is the hormone that suppresses urine production during periods when the body does not need to eliminate fluid. Alcohol directly inhibits ADH secretion from the posterior pituitary gland, causing the kidneys to produce urine at a significantly higher rate than they would otherwise. A standard drink, 1 glass of wine, 1 12-ounce beer, 1 shot of spirits, has been shown in pharmacological studies to produce a measurable reduction in ADH secretion within 30 minutes of consumption, with the resulting diuretic effect lasting 2 to 4 hours. For a man who has a beer or a glass of wine at 9 p.m., the diuretic effect is maximal between 10 p.m. and midnight, precisely when he is trying to sleep. His kidneys produce urine at an elevated rate during the first hours of sleep, filling his bladder faster than it would fill without alcohol, and he wakes up with urgency earlier than he would have without the drink. The second mechanism is alpha-adrenergic stimulation of the prostate and bladder neck. As alcohol metabolism produces acetaldehyde and alcohol itself acts on adrenergic receptors, there is an indirect increase in sympathetic nervous system activity that affects the smooth muscle in the prostate capsule and bladder neck. The prostate capsule contains abundant alpha-1 adrenergic receptors, which is why alpha-blocker medications like tamsulosin and silodosin work for BPH by blocking these receptors and relaxing the prostate smooth muscle. Alcohol-mediated sympathetic activation stimulates these same alpha-1 receptors, producing smooth muscle contraction in the prostate and bladder neck that increases outflow resistance. In a man who is already taking an alpha blocker for BPH, evening alcohol consumption is directly antagonizing the therapeutic effect of his medication. The third mechanism is direct bladder wall irritation. Alcohol and its metabolites, particularly acetaldehyde, are excreted in the urine, where they come into direct contact with the bladder urothelium. Acetaldehyde is a mucosal irritant that increases the sensitivity of the bladder wall's sensory nerve endings, the C fibers that transmit urgency signals to the brain. An irritated bladder urothelium generates urgency sensations at lower bladder volumes, produces more frequent and more intense urgency waves, and is more prone to the involuntary detrusor contractions that characterize overactive bladder. Multiple urodynamic studies have demonstrated that alcohol consumption significantly lowers the volume threshold for first urgency sensation and reduces maximum systometric capacity, meaning the bladder effectively becomes smaller and more reactive after alcohol intake. The fourth mechanism is inflammation of the prostate through prostaglandin activation. Alcohol consumption activates cyclooxygenase enzymes in prostatic tissue, promoting the production of pro-inflammatory prostaglandins, the same chemical mediators involved in arthritis and other inflammatory conditions. Prostatic inflammation produces swelling of the gland that temporarily increases urethral obstruction, worsens lower urinary tract symptoms, and can contribute to the chronic prostatic inflammation that is increasingly recognized as a contributing factor to BPH progression over time. A 2010 study in the European Urology Journal found that men with chronic prostatic inflammation had significantly more severe lower urinary tract symptoms and faster prostate growth rates than men without inflammation, and that alcohol consumption was among the dietary factors most strongly associated with elevated prostatic inflammatory markers. The clinical evidence for alcohol's impact on urinary symptoms is consistent across multiple large epidemiological studies. A landmark analysis published in the British Journal of Urology International followed over 2,000 men with lower urinary tract symptoms over 5 years and found that men who consumed alcohol regularly, more than 7 drinks per week, had significantly more severe Lutz scores and significantly faster symptom progression compared to non-drinkers or light drinkers, even after controlling for prostate volume, age, and other confounding factors. Men who reduced their alcohol consumption during the study period showed measurable improvement in symptom scores within 3 months of reduction. The practical recommendation I make to my patients is not necessarily total alcohol abstinence, though total abstinence produces the most dramatic urinary benefit. The most impactful single change is the elimination of alcohol consumption after 6 p.m. Moving any alcohol intake to early afternoon, if a man chooses to continue drinking at all, decouples the diuretic, irritative, and obstructive effects of alcohol from the nighttime sleep period. This single timing adjustment, consuming alcohol at 1 or 2 p.m. rather than 9 p.m., is reported by many of my patients to produce a meaningful reduction in nocturia frequency within the first week of implementation, before any other changes are made. For men who are willing to eliminate alcohol entirely for a trial period of 4 weeks, a urological elimination challenge that I formally prescribe to patients with significant nocturia, the results are consistently striking. Most report a reduction of at least 1 to 2 nighttime voidings per night within the first 2 weeks. Some report the complete resolution of the urgency pattern that had been waking them up at 2 a.m. The prostate did not shrink. The BPH did not reverse. The bladder did not surgically repair itself. The removal of the consistent chemical insult simply allowed the natural function of the lower urinary tract to operate without the 4-mechanism burden that alcohol had been imposing every evening. Share this video with every man you know who drinks regularly and deals with nighttime urination. Leave a comment below telling me whether you will try the evening alcohol elimination challenge. Like and subscribe. I will see you in the next video.